Hello, everybody, and welcome to ePCR. I am today together with two good friends and great experts in the field of mitral interventions. I'm with Marta Sitges and with Saibal. And today we will talk about MitraClip and tailoring mitral valve repair to improve patients' outcome. We are going to talk about the contemporary evidence in this field. It's a field which is rapidly evolving. MitraClip therapy is becoming a mature solution for many patients. The spectrum of available devices is expanding, and so we are expanding our options, our alternatives. On the other hand, this expansion needs also some evidence to guide our decisions. For this reason, we will hear from Saibal the learnings from the largest contemporary real-world all-comer mitral valve repair outcome study, EXPAND study, of which Saibal and myself are the principal investigators. I will focus on the evidence-based recommendations for clip selection, which will be a kind of mix between expert opinion and available evidence. Marta will talk about the clinical importance of visualizing these lesions. It's a very important point that this is a totally image-guided procedure. Imaging plays an important role. And finally, Saibal will bring us into the future, what is coming next from his perspective as a United States operator and worldwide operator, and from the perspective of Abbott. So without any further delay, I would like to give the word to Saibal for his presentation.
Well, thank you, Francesco and Marta. It's very nice to be together on in a Zoom system, in a very realistic and unrealistic system, where it's night for me and day for you, right? I'm half asleep, but I'm going to share my talk. And I had the privilege of working with Francesco as the co-principal investigator of the EXPAND registry. And I'm going to share some data on the contemporary clinical outcomes with the MitraClip NT-XTR and this core lab echo results from the 1,000 patient global EXPAND study. This is this contemporary outcome study was actually presented by Dr. Roth-Baer, and I'm just going to present that data on his behalf. These are my conflicts of interest. So why this study? Well, Abbott introduced an additional implant size with the next generation MitraClip NTR and XTR in 2018. The EXPAND study was initiated to evaluate the real-world clinical experience and outcomes associated with the use of the MitraClip NTR and XTR system. The difference fundamentally being that the NTR was identical to the previous generations, excepting for some modifications of the grippers and the delivery system. But the real change was the addition of the MitraClip XTR, which was a slightly longer arm, which would allow you to treat a wider group of pathologies. The EXPAND registry was a prospective multi-centered single-arm international post-market real-world observational study. There was a minimum of 1,000 consecutive patients. Subjects were consented to receive the MitraClip NTR-XTR in 60 sites in Europe and US. And the key outcome measures was MR severity with procedural measures and major adverse events, quality of life, functional capacity. And the data adjudication was for all cases. There's a clinical event committee for adjudication of adverse events, and there was an echo core lab for echo measurements, and there was an independent physician committee for the evaluation of single leaflet device attachments and leaflet damage issues. So 1,041 patients were consented and underwent the MitraClip procedure. However, 117 subjects, we had missing baseline images, and 99 patients could not be evaluable by the echo core lab. Based on this, we had 835 subjects with adequate imaging by the core lab. 422 were primary MR or mixed etiology, 413 was secondary MR. How was the study executed? There were two echo core labs. And the primary echo core lab number one was primarily utilized for the assessment of the MR etiology and assessment of MR severity at baseline and follow-up. And the reason for using this core lab was because this core lab participated in the Everest 2 realism and quad trials, and to maintain a continuity and to allow us to compare different data sets, it was important to keep this core lab. The second core lab was utilized to understand the baseline mitral valve anatomy characteristics and LV dimensional measurements during the study and follow-up. And that's why we had this. Now, the baseline MR severity was assessed based on the American Society Echo Guidelines. And this is very important because there's a fundamental slight difference in the AAC guidelines and the European guidelines, especially for functional MR. Now, if you look at the procedural outcomes in comparison to the previous studies, you can see that the actual implant rate was very high, was almost 99%. The procedural success rate was the highest compared to the other studies. It was about 96%. The device time was short, 45 minutes. The fluoroscopic time was 17 minutes. The procedure time was 80 minutes. And the length of stay was about 6.5 plus minus 7 days. However, if you look at the US patients, the numbers were smaller. I think there's a difference of practice between Europe and US. When it comes to the core lab adjudicated MR severity by etiology, on the left side is primary MR and the right side is secondary MR. And if you use the ASC guidelines, then you can see that about 71% of patients actually had 3 plus or 4 plus mitral regurgitation. And then you can see at 30 days, 87% of patients actually had 1 plus MR, which is actually pretty impressive, much better than what we had achieved previously. Now, if you look at the secondary MR, you can see that about 39% of patients were considered to be moderate MR. However, if you used the European guidelines, then a higher percentage of patients would be considered to be severe, because in the European guidelines, an ERO2 is considered to be severe. So that's the fundamental difference of why these numbers look a little bit different. Now, here are the adjudicated LV and mitral valvular annular dimension changes. What you can see over here is that the LV end diastolic diameter and diastolic volume reduced significantly at 30 days in the all group, as well as in the primary, as well as the secondary MR group. There was also evidence of remodeling of the annulus, and you can see there's a reduction in size of the annulus, both in the primary MR group and the secondary MR group, which actually goes with the technology that basically when you put a clip in, it actually stabilizes the anteroposterior diameter and prevents the annulus from dilating, or actually helps in reduction of the annulus itself. If you look at the functional capacity and quality of life, there's an improvement in the functional class in both the primary and secondary MR group. You can see the majority of the patients were NYHA class 2 or less, compared to most of them who were actually 3 or more. And if you look at the quality of life score, 30-day, you can see there's an improvement compared to baseline, both for the patients with primary MR and secondary MR. And this is something very similar to which we had seen in the quad trial. So why is this important? Well, this study represents the first contemporary report of a echo core lab and a CEC adjudicated 30-day clinical outcome in patients with both primary and secondary MR treated with the new MitraClip NTR and XTR system. Second is the results show that the MR reduction to mild or less was achieved consistently with the current generation of NTR and XTR, and the degree and the significant reduction of MR was associated with an incremental reduction in LV volumes, as well as a significant improvement in quality of life and functional capacity. What is really important is to understand that this was the first study that demonstrated that we had achieved 1+ MR at 30 days in over 85% of patients, which we did not do in the Abbott trial. Okay? Now, despite the discordance seen in the baseline MR severity between sites and the ECL, the clinical benefit was seen across the study cohort, highlighting the challenges in the quantitative assessment of MR severity in current clinical practice. And therefore, we suggest that in clinical trials, it is good to have a core lab. Finally, the EXPAND study confirmed the safety and performance of the next generation MitraClip system for the treatment of primary as well as secondary MR. So the essentials to remember from this presentation: why the next generation MitraClip NTR XTR with an additional implant size, what the safety and performance of the MitraClip NTR and XTR evaluated in the real world setting, how did we do it? We had an independent echo core lab as well as a clinical events committee. And what were the results? Adjudicated safety and performance outcomes confirms the safety and effectiveness of this new system. And why is this important? This is the first full echo core lab adjudicated report of 30-day primary clinical and the largest contemporary data set on the use of the next generation MitraClip NTR and XTR system. Thank you very much. This gives me a great pleasure to allow Francesco Maisano to speak in his own session. And I had the greatest privilege of actually being the co-PI with him in this EXPAND registry. And hopefully we will be working together in many more studies to come.
So thank you very much, Saibal, for the kind introduction. Obviously, I look forward to bring more evidence in this field. For today, I will focus on what we learned from the global EXPAND study in this specific initial report. We will report on clip selection strategy and outcomes with MitraClip. And I talk on behalf, obviously, of the full investigator team. These are my potential conflict of interest. Of those, the most important is that I am a consultant for Abbott. Why this study? This study was conducted after the introduction in commercial use of the NTR and XTR systems in 2018. And the idea was to support clinicians with some evidence to guide their decision-making during the procedures because of the new availability of a new device, so 2 different sizes. In a pre-market limited commercial limited study where only few centers were involved with high volume operators, an advisory board prepared this table that you can see here, where we tried with limited experience to provide suggestions for clip selection. And we came out with these recommendations, which were favoring XTR systems in presence of longer leaflets anatomy, in presence of central lesions, in presence of large flay with redundant leaflets, while a smaller device would be favorable in patients with short or restricted leaflet motion, in patients with calcification of the annulus or calcification of the leaflets, in patients with a smaller mitral valve area, and in those patients where the lesions were more commissural due to the risk of potential clip entanglement in these areas. Obviously, these were just opinion based on our own initial hands-on experience, and we were obviously sure that this was not the final recommendation. We should evaluate according to data, and this came with EXPAND study, which is a prospective multi-center single-arm international observational study with a core lab, like we just heard from Saibal. And again, the primary goal of this study is to provide a recommendation for clip selection. So for this reason, we reviewed all those cases which were able to be adjudicated by the core lab, and we came out with almost 1,000 patients undergoing MitraClip therapy, 544 having both XTR and NTR. Most of them had XTR only, 74%, and 360 patients with NTR only clip. So we created these two groups where it was very clear there was one group receiving only small clip devices and one group having a mixture of the two different sizes, but with a large prevalence of large clips only. And in these two groups, we compared the reduction of MR severity by at least more than 2 grades and the rate of major adverse events and leaflet adverse events. At baseline, the two groups were significantly different in many respects. But it must be noted that there was no preset strategy. The operators were free of choosing the size according to the anatomy without any structured guideline from the leadership of the study, and there was nothing in the protocol suggesting one or the other clip size other than our recommendations that I shared with you at the beginning of the presentation. So the operators were free of choosing what they wanted, and the operator had a tendency to choose larger clip sizes in patients with more MR, in patients with larger left ventricular and diastolic volumes, and in patients with larger annular dimensions. Overall, there was a slight tendency to treat primary MR mostly with XTR than with NTR. When we look at the anatomical predictors of improved outcomes defined as a reduction of more than 2 grades at least, there was some interesting issues in primary MR, where we found that XTR was better than NTR only in patients with higher degrees of MR and complex mitral valve anatomy. In patients who had a larger prolapse gap, so again, more complex anatomy in terms of the specific localized problems of leaflet grasping, and in patients with larger anatomies, we found a little bit less significant difference, but still a tendency here. In secondary MR, on the other hand, we didn't find any predictor of reduction of MR, underlying the fact that this is a more complicated situation, and obviously in secondary MR, there are many patients who still can be well treated with NTR. Basically, there was no difference according to the complexity of the anatomy in terms of pre-procedural MR, in terms of the tenting area and leaflet tethering, as well as in terms of the size of the ventricle or the size of the annulus. Very importantly, we look also at the anatomical predictors of major adverse events and leaflet-related adverse events, including single leaflet attachment. And we found no pre-procedural feature predicting for these events, which means that basically both devices performed pretty well in this setting. According to what we found overall in this data, we came out with a slight change in our recommendations. So in primary MR, XTR is associated with greater MR reduction in patients who have higher degrees of baseline severity of the mitral regurgitation. It was also interesting something to see that in patients with smaller left ventricular dimensions, and particularly in patients with small annular dimensions, XTR was associated with better outcomes. This goes in contrast with our previous recommendations, which were based on the idea that XTR could be associated with higher degrees of gradients. But on the other hand, using XTR in small leaflet anatomies may be more effective, and therefore single clip implantation could be more efficient, reducing, at the end of the day, reducing the risk of creating inappropriate gradients. Obviously, XTR was more efficient in patients with larger prolapse gaps and in patients with more complex valve anatomies. When we look at the risk of taking one or the other clip device, you saw no difference both in primary and secondary MR, and XTR and NTR were equally efficient in all subgroup of patients with secondary MR. So this probably requires further investigation, but at this time we don't see any signal that suggests the use of smaller or larger clips in the overall population. So why this data and why this evidence is important? First of all, this is the first time that we can recommend clip selection strategies based on core lab adjudicated data. It's a very important aspect which has to be not underestimated. MitraClip remains a procedure which is highly operator dependent. The EXPAND study is trying to bring evidence so that most of these decisions could be supported by evidence. What we found, particularly in primary mitral regurgitation, XTR achieved more favorable MR reductions in patients with more severe baseline MR, in patients with large prolapse gaps and complex mitral valve anatomy, and very importantly, in patients with smaller annular dimensions, underlying the fact that a longer clip arm is associated probably with more efficient MR reduction and reduces the need of a second clip implantation, which is in those patients increasing the risk of creating unfavorable gradients. At this moment, there is no evidence of any advantage of clip selection strategy in secondary MR. However, this is a univariable model of analysis, and we will go for further investigation in this field to find if there is any subgroup of patients who benefit from any clip strategy. This is overall an observational study, and therefore we need to further investigate our data to refine the clip selection strategy. So in general, we believe that a recommendation based on safety and MR reduction guided by core lab generated evidence will provide real world guidance for physicians to individualize transcatheter valve repair based on patients' mitral valve anatomy. And this leads to my last slide that I let you to read and to think about because it's just underlying again the same concepts. I think is a very important study which is supporting decisions in this new therapy which is now really becoming very mature and a real alternative to cataract surgery for those patients are high risk for surgery with degenerative or functional MR. Thank you for your attention. And now we are to the third lecture, which is underlying the importance of appropriate imaging prior, during, and after these procedures. And who better than Marta Sitges can give us this lecture on critical importance of appropriate mitral valve leaflet visualization. Marta.
Thank you, Francesco, for the introduction, and thanks for the invitation on this session. So during the upcoming 10 minutes, I will focus on the importance of adequate quality imaging for patient selection and guiding the procedure. So we are dealing now with a disease which is severe MR, but we can face indeed several underlying diseases in this severe MR. So severe MR is not always the same, and this is why current imaging modalities are so important to squeeze all the information that we can, so we can be now able to give a precise diagnosis and description of the functional anatomy of the mitral valve, which does not only stay on quantification and evaluating the hemodynamic impact of this valve dysfunction as we used to do in this past, but we are also now able to provide a precise characterization of the lesions and the valvular and subvalvular apparatus anatomy, functional anatomy. This is very important for selecting the most adequate and personalized treatment for each patient. And now with the availability of several types of devices and even types of MitraClips, this is even most important. So the first thing to do is to really understand how is the functional anatomy of the mitral valve in a given patient. For that, we really need to do a systematic valve analysis, focusing on which is the dysfunction, what are the lesions, and what's the etiology of mitral regurgitation. For that, it's important to have an adequate training, an adequate expertise in understanding the mitral valve. So how do we perform this systematic assessment of the mitral valve? We always follow the same systematic, and this is important, always do all the same systematic approach, always the same views, not to forget any little detail. To these 6 views that we propose using TE, just scanning all the dimensions of the mitral valve. We also add 3D echocardiography, which has some advantages, particularly in the degenerative disease. We can see the width of the prolapse. Also in functional mitral valve disease, we can see the size of the orifice, the shape of the orifice, and with that we can change our strategy in placing clips or even in potentially in selecting the size of the clip as we have previously been discussing. So very important always to follow all these views, always the same views, and always systematic, not to forget any little detail. From there, we can also have our mental systematic approach, like following our mental scheme, saying, looking at what's the type of dysfunction, where is that dysfunction localized, and from there, looking at the lesions on the valve, and from there, describing which is the etiology of the disease, which is important also because strategy may differ. So here we can have patients with functional, as you know, or primary degenerative mainly, or other types of organic disease on the mitral valve. But also keep in mind that we can have patients with mixed etiologies, particularly those with functional or secondary MR, but with also some degenerative disease, like these patients that we are showing with a small chordal rupture. So once we have done this systematic analysis, following all these views, adding 3D and having our mental schematic approach, we have always to be pursuing our second mass, which is get the best image quality. And this is not a matter of being picky, it's a matter of need the essential need to look to see adequately the leaflets of the mitral valve. This is very important because for patient selection, that's key. I mean, we always want to have long leaflets with adequate tissue, no calcium there. While if we have like in the second row image, if we can have their small leaflets that may prevent from implanting a clip or even change our strategy. So like being more prone to put smaller clips as discussed before. Also, we have to be always trying to optimize our best and doing the best possible image. This is very important. This is just an example to show you like small movements shown in the TE probe, very small, very tiny movements can get a better image. So this is exactly the same patient. The two loops are exactly the same patients. We all prefer to see the video on the center of the image as compared to the one on the left, where we can see much worse the posterior leaflet. It's exactly the same patient, just 2 seconds, one movement of the probe, or just changing a little bit the settings of the echocardiograph, of the machine. And this is especially important to remember. All these knobs in the machine are not decoration. They have a utility, and we have to remember them. So it's not only the hands of the echo that can improve, of the echocardiographer, that can improve the image quality, but also playing with these buttons can make an important change, a needed change to better visualize the leaflets. And especially that's important for selection of the patient, as we have said before, but it's really critical when we go to grasp and capture the leaflets. Why? Because we really need to see the leaflets laying on the arms of the device, and we really want to avoid losing one of the leaflets. It's very important to have a perfect image like we have here, where we can even see the leaflets inside the grippers and the arms of the device. So just even sometimes we need to really stop the image, the video, and go frame by frame as we are going, as we are showing in this slide, to really ensure that we have a good capture of the leaflets and a good grasping. Once we have done the grasping, it is also essential to have a good image quality to see how much leaflet we have inside the device, and also to see that the leaflets are tight and are perfectly captured within the device. So remember these essentials for have an adequate, and to ask for an adequate image quality to your echocardiography, adequate expertise and training. Also remember that you don't have to, it's like when you are moving catheters, you never stop moving, small movements, same for the TE. So keep on moving the probe, keep on getting all the time the best image quality, and also remember to touch the buttons and to optimize the settings of your machine to get the best image quality. Finally, third must to get an adequate understanding of the mitral valve and an adequate imaging to guide the procedure. A team approach attitude. That's important. Why? Because as said before, we as echocardiographers or imaging is the eyes of the operator. So it's very important to have, as I have said, a very good image quality to guide the procedure, but it's very important to have a team work. So we have to see, operators and imagers have to see exactly the same. We have to talk in the same language and see exactly the same. So that means that we really need to work together, following the same systematic approach to valve analysis, understanding the same way to see the mitral valve, and talking on the same language. Because if I say something with my operator, he or she immediately understands what I'm saying, what I'm talking about. And for that, it's important to have this co-training together and work together. We need a partner to dance. And it's good that the partner is most of the times the same. So we really talk the same language and we have the same systematic approach. So this is my final slide, just to sum up and to remind some take-home messages that I would like to highlight. So remember that echo is your eye for the intervention, to do the intervention. You really need a good image quality. So as you as an imager need to be constantly pursuing this perfect or optimized image quality. That's essential to have a good visualization of the leaflets of the valve and to understand what's going on the valve. Finally, not to miss anything, you need to go with following your systematic approach, always the same views, always your same mental agenda to follow and to understand what's happening on that mitral valve and during the procedure. And finally, use a common approach with your teammate with a team approach attitude. Thank you very much for your attention.
Thank you, Marta. It was outstanding presentation. Particularly, I love the idea of the heart team and the need for a partnership in this kind of procedures. I always say these are at least two operators procedure. There is one person operating on the device and one person operating on the images, and there is no way we can do differently. Now, let's go back to Saibal because we had discussed about XTR, NTR, but there is more coming. So the next presentation will be what does the mitral valve repair future hold? And this is going to be Saibal again.
Well, thank you very much, Francesco and Marta, for allowing me to share this last presentation on the session, What Does Mitral Valve Repair in the Future, in particular interest regarding MitraClip. What do we have in future? I would just say a few words about the further modification of the MitraClip, the Gen 4, which is available now in the US, and then a few words about a new trial. So when you look at the Gen 4 MitraClip, it has 4 clinical clip options. So we have NTW and XTW, which is the wider versions of the NT and the XT. And therefore, we now have 4 clip sizes, NT and XT, NTW and XTW. In addition, you have a controlled gripper actuation, which allows independent grippers to be aligned and dropped. It's simplified the procedure. There's precise and controlled steering. In addition, you can actually measure left atrial pressures directly from the guide catheter. This is the characteristic which is between. You can see over here on the left side, the regular clip is about 4 millimeters, and the wider clip is about 6 millimeters. And similarly, you have with the G4XT and the G4XTW. If you look at this length of the clips, the XTW is about 12 millimeters long compared to 9 millimeters in the NT. So when you're using an XTW, you get a wider as well as a longer grasp of the leaflets. These are the controlled grip actuation, and you can see over here that individual grippers can be pulled back while the other one still stays on the leaflet. So this allows you optimization of grasping of the leaflets. So here's an example of an XTW being used. This is actually the first case in the world being used in our hospital. And you can see this is a patient with a flail posterior leaflet with mitral annular calcification with a moderate size flail gap. And we thought that perhaps the best way to do it was using a single XTW right in the middle. So the clip was aligned, and you can see this is the baseline T views, biconventional and X-plane view LVOT, showing a very thickened posterior leaflet. That's the clear eccentric mitral valve jet. And then you can see over here, I'm looking at the grippers. Do you see the independent gripper actuations that are only activating the anterior grippers just to align it? And finally, you can see the clip is well aligned. And then once you're inside over here, when you grasp the leaflets, it's important to actually make sure that the orientation is perfect even after you grasp the leaflets, because if you use a wide clip and you don't orient it even after grasping, you can actually cause distortion of the leaflets. And then finally, when you grasp the leaflets with single clip in 15 minutes, there's trace to no mitral regurgitation with just one XTW. And this is what it looks like with a nice bridge. And perhaps if we use 2 clips, we might have got a slightly increase in gradient. Now the gradient was only 1 millimeter mercury. This is an example to show you the NTW and to demonstrate the independent gripper function. And you can see over here, if you look at the leaflets, you can see over here that the posterior leaflet is rolled in. So we had removed the gripper from the posterior leaflet, saw that the posterior leaflet is rolled in. Then we advanced the whole clip system, allowed the leaflets to sit better on the ventricular arms. And then we saw when it's in a better position and not rolled, then we dropped the gripper of just the posterior leaflet. And then once you drop the posterior leaflet gripper, you can see now the posterior leaflet is nicely inside and the gripper is bouncing and you saw a much better grasp. And that leads to a better leaflet insertion and a better reduction of MR. And you can see a very nice tissue bridge with a single NTW and using the independent gripper function. And the gradient was only 2 millimeters of mercury. So with that, I'm just saying a few words of a new study based on the fact that we have now 100,000 patients with the MitraClip, based on the fact that with the EXPAND registry, with the new generation MitraClip, we have much better reduction of MR. It's time to now evaluate the MitraClip in lower risk patients or moderate risk patients with MitraClip in primary MR. So this is a repair MR trial, which is patient with primary MR who had moderate surgical risk, who will be randomized to either mitral valve surgery, repair versus a MitraClip. And about 500 patients will be enrolled in 60 sites in the US, Canada, and probably in Europe. And it's going to be randomized 1-to-1, and there's going to be an echo core lab, of course. And this is what it looks like. The co-primary endpoint is going to be all-cause mortality, stroke, and cardiac hospitalizations with clear-cut definition, or acute kidney injury requiring renal replacement therapy at 2 years. And in the first 30 days post-treatment will be excluded. And a co-primary endpoint of proportion of MR patients with moderate or less without the need for a mitral valve replacement at 2 years. So these are the proposed primary endpoints, and there are also some important secondary endpoints. And so I would like to end by saying that the new generation MitraClip will help improve the efficacy, efficiency, and the safety of the procedure. And the new trials will hope to help expand the population treated by transcatheter mitral valve repair. Thank you very much.
Thank you very much, Saibal. This was a nice overview as well as fantastic demonstration of real-world application. And now we are at the end of our session. I would like to summarize what we learned from our presentations. I think, first of all, we presented our initial findings from the largest contemporary real-world registry, the EXPAND registry trial, which is creating evidence-based decision-making recommendations for navigating through the broader spectrum of alternatives within MitraClip therapy. I think it's important to mention the importance of registries and the complementary roles of randomized controlled trials and registries in our practice. Randomized trials and registries are complementary, particularly in this field, which is highly operator dependent. With these registries, we can record user experience for many users, and we can understand what is the change in practice in this field, which is now really evolving very rapidly. Last but not least, Saibal, you showed us that there is a new kind of Everest trial. The new DMR study is more appropriate for the current generation device, and we will see whether transcatheter therapies will really compete in intermediate risk profile patients with standard of care, which remains today surgery. Okay, so with this, I would like to really thank my colleagues, Marta and Saibal, who were able to deliver a fantastic session. Again, I've been together with Saibal more focused on the technical aspects, while Marta was delivering a great presentation on imaging, which the two things are not opposed. I mean, I think the message from Marta was the most important one, that we need a real heart team collaboration, and heart team which is focused on the patients, focused on the outcomes, is a heart team that collaborates as a single unit and is learning every day from our practice. So with this, I would like really to thank you for the last time, and I hope that I will see you soon and that we will be able again to physically meet in some next event.